Hello, everybody, and welcome to recording 3 of the Stroke and Acute Intracranial Problems. Let's go back to our last subject that we were talking about and talk about some more specific nursing interventions and things that might be used to help or treat a patient who has a intracranial hemorrhage. And we had a 22-year-old construction worker that came in with signs and symptoms of some kind of intracranial problem, complained about the worst headache of his life, had a sudden increase or increase in signs and symptoms of rising intracranial pressure, such as altered mental status, and the patient was vomiting, vital sign changes, and the patient was intubated to protect his airway and also likely because he wasn't adequately providing enough ventilation and respirations. And so with the intubation, of course, he's going to be placed on a mechanical ventilator, and then they do some extensive radiologic studies. Of course, you are looking at a CT scan and an MRI, and then they'll probably do an arteriogram. And with all of these tests, they'll be able to identify what the specific problem is. And in our scenario, this individual is diagnosed with a subarachnoid hemorrhage. So what is a subarachnoid hemorrhage? A subarachnoid hemorrhage is likely caused from an aneurysm that ruptures, as you can see here. And if this aneurysm occurs because either there's some kind of anatomical anomaly from birth, or because of the pressure of hypertension, you can get the weakening of these blood vessel walls and they balloon out. And because just like any balloon that is constantly blown up and then deflates, blown, you get a weakening in the walls and that wall can rupture. And that's what is a cause of the aneurysm rupture. And because of where this blood vessel is located in the brain space that's located, it's located in the subarachnoid space, then you have bleeding almost directly onto the brain. So what is the treatment for this? I do believe Dr. Reed goes through this in her notes. These individuals can have a clipping or a coiling so that blood will stop shooting into this area, making it bleed further. So let's talk about after the surgical procedure, the ICU nurse continues to manage the intracranial pressure by draining the CSF, and that's because of a ventriculostomy that had been placed by the neurosurgeon. Mannitol was administered to control the cerebral edema, cause diuresis, and manage the ICP. That's the main reason why you give the mannitol, is to draw fluid out of the brain cell and then to cause diuresis so that fluid is permanently removed. Blood pressure, heart rate, and ABGs are now within accepted parameters, and then we're going to do neurochecks every hour are unchanged. This patient still has a Glasgow Coma scale of 8. So when we look at additional healthcare orders, we notice that Nimotop or nimodipine has been ordered. Notice that nimodipine is the generic term, and in this course, as is on NCLEX, there is a trend of going towards generics. So whether I give it to you or not, make sure that you know all of the generic terms for the drugs that are presented in this course. I don't always catch it because I'm such a name brand person, but you need to know the generics. The individual is on Dilatin, phenytoin, I'm sure that's not how you say it. You've got Decadron, and then we're going to NG tube clamp to low suction to manage the vomiting. So let's provide an indication for the medications, especially the medications that you may not be familiar with. As I said, with a subarachnoid hemorrhage, this is the space that is closest to the brain. So whenever there is a hemorrhage, you have blood that is sitting on top of the brain, and especially if there's an intracerebral, a blood vessel that's deep within the brain that ruptures, you definitely have blood that's on the brain that comes in direct contact with the brain cells. And what happens when blood comes in direct contact with the brain cells is it triggers inflammation, and with that inflammation will cause the blood vessel to spasm, and the blood vessel spasming means it will vasoconstrict, vasodilate, mostly vasoconstriction, and that will reduce blood flow to those nerve cells that are not getting a lot of blood anyway. So this is a problem. So what is given is nimodipine, because as a calcium channel blocker, this will vasodilate the blood vessels, and it will cause or decrease the vasospasm that's associated. So you can see the picture here, so you can see how narrow this blood vessel becomes, which means whatever blood flow is downstream can be reduced. Blood vessel spasm has the potential to decrease blood flow, causing ischemia. So the key thing with nimodipine, because any blood vessel vasodilator has the potential for lowering the blood pressure. And as we've already identified, the ICP minus the MAP is going to give us the cerebral perfusion, or the MAP minus the ICP is going to give us cerebral perfusion pressure. So if you dump your blood pressure because you're giving a calcium channel blocker, well, then that has the potential to dump your CPP. So again, we don't want the blood pressure too high. We don't want it too low. Again, we need that just right value. Dilantin, you already know, it's an anti-seizure medication, and anybody with an inflammatory process in the brain or having a stroke is at risk for seizures. Here's the key thing that you have to remember, that a seizure is going to be this abnormal firing of the neurons, and it's a very rapid fire. And if I said to you, go run from here to Dallas, you know that your cell's metabolic rate as you run are going to increase. And anytime there is an increase in the metabolic rate of your cell means there's going to be a higher demand for oxygen. And if you have a brain problem and you have a nerve cell that is seizing, which is going to cause an increase for oxygen demand, with any kind of intracranial problem, there may be a problem with delivery. Again, CPP can always be reduced because of the brain swelling, and therefore, when you have a higher demand for oxygen needs, you may not be able to meet that demand, and therefore you have to be sure and chill, sometimes literally, like cool these brain cells down so that the metabolic demand is decreased. And you definitely don't want anything that will cause an increase in oxygen demand or oxygen need or the metabolic demand. Decadron, we've already talked about, that's the brain steroid. It's similar to hydrocortisone or solumedrol, and it doesn't cause as much sodium retention because, again, we don't want this patient to be fluid overloaded because we don't want fluid to move into brain cells. The nurse maintains strict aseptic technique. Recall that we have this ventriculostomy. We got a burr hole through the skull and into the brain, which means we have a direct pathway for pathogens. What would happen if there was a pathogen in the brain cell? And we are draining CSF because the intracranial pressure is very high. But let's consider the patient's mechanically ventilated. The assist control's at 600, but the FiO2, the supplemental oxygen, is 40%. So if you calculate the CPP, if you take the MAP minus the ICP, and you know that the CPP is dangerously low, would we help the patient's oxygenation in the brain if we increase the FiO2 up to 100%? And why is it important to use strict aseptic technique when manipulating the ventriculostomy drainage system? So first we address the fact that we've calculated the CPP and it's 57, and we know that anything less than 70 and definitely less than 60 means that perfusion to the brain is decreased and the brain cells are lacking oxygen. So why don't we give 100%? Why don't we put that supplemental oxygen up to 100%? Well, if you go back and look at the saturation's 100%. The body has plenty of oxygen. It's the brain itself. It's only the brain that is lacking in oxygen. And increasing the supplemental oxygen is not going to help necessarily in bringing up more oxygen to the brain. We have to get that ICP down because a high ICP is restricting or preventing the necessary blood flow into the brain, into the head. The heart and the kidneys are doing just fine. They've got all the oxygen they need. It's the fact that we cannot get blood flow up into the brain that's the problem. And if we don't do anything about lowering the ICP, then this individual will die from brain death with an oxygen saturation, with a blood oxygen saturation in the entire body of 100%. So you have to get the ICP down, and that's the whole point of draining CSF. Why is it important to use strict aseptic technique? Well, again, we have a ventriculostomy. We've created an open pathway for pathogens into the brain, and this individual is at risk for an infection. So any kind of infection is going to do what? It's going to raise the metabolic rate of nerve cells. And because we're having a problem delivering enough oxygen to those brain cells because of a high ICP and a worsening CPP, we just cannot afford to put this patient at risk for increasing the metabolic rate. Now, you might say to yourself, well, there is also a problem with the brainstem. If the brainstem is not operating the respiratory system very well, recall that the brainstem is also the seat of thermoregulation. And patients, even if they have no ventriculostomy, if their temperature goes up, if they become hyperthermic, that can be a result of the brainstem whacking out, as in it's not functioning well. But regardless of whether the elevation in temperature is caused from a brainstem issue or a pathogen, you are increasing the metabolic demands of the brain tissue, and we need to get that temperature lowered as quickly as possible. These patients are often given antipyretics such as acetaminophen, and they will be put, a cooling blanket will be put on him. So time passes for our patient, and we are successfully able to treat this patient. The patient's condition improves. So he's eventually transferred to a medical surgical unit to continue his recovery. You know, he's going to have physical therapy and all kinds of things to help in his recovery. And then on post-op day 5, the patient complains of a sudden severe headache. He's restless, and he's weak in his arm and legs. So what might these clinical manifestations indicate, and what diagnostic exams might be ordered? Well, the clinical manifestations or the signs and symptoms indicate that this patient may have what's known as severe vasospasm with subarachnoid hemorrhage. So this is a situation that occurs not with individuals who have ischemic strokes. This occurs within individuals who have subarachnoid hemorrhages. At the 3 to 14 day, with day 5 as the most common, vasospasm occurs. And with that, the artery is severely narrowed, which reduces the blood flow to the brain. And so if you said to me, well, wait a minute, his signs and symptoms seem like the patient's having a stroke. And that's what it looks like. This profound vasospasm, because they have a headache, can look like an intracranial hemorrhage, because these patients are always at risk for rebleeding, or they can have an ischemic stroke, or this can be vasospasm. So you've got 3 possible causes of these signs and symptoms. And because it is a subarachnoid hemorrhage, in 70%, these individuals do get vasospasms. So that's why, that's probably what it is. But what are we going to have to do? What diagnostic exams we're going to do? Well, probably the patient will first get a CT, because they'll get the CT first to ensure that the patient does not have a rebleed from the subarachnoid hemorrhage. And of course, now we're going to be looking at, well, is there a stroke? Is it an ischemic stroke, or is it vasospasm? And so the next thing that will be done is likely a transcranial Doppler. And a transcranial Doppler will use ultrasound to examine the arteries. So they're going to be able to measure blood flow and look for signs of vasospasm. And so that will help for the physicians to confirm that this patient has arterial vasospasm. So once that's confirmed, then triple H therapy is usually prescribed. So what is triple H? So again, I want to remind you that vasospasm occurs in 70% of patients with a subarachnoid hemorrhage. This is not a problem seen with ischemic strokes. This is unique to subarachnoid hemorrhage. Triple H is the description of three types of therapy that is given for patients with arterial vasospasm. So first, we want to raise the blood pressure. And I know that sounds like, wait a minute, this is counterintuitive. But you have to increase the force of blood flow because that is what's going to help push blood or help blood flow through those vasospastic arteries. So this patient may be on a very controlled hypertensive regimen. And so they may give a drug such as phenylephrine, which is a powerful vasoconstrictor. What kind of vasoconstrictor? An IV vasoconstrictor. We need this to be very, very carefully controlled. Then these individuals may have hypervolemia. Again, when you increase blood volume, fluid volume, then that will help push blood through those vasospastic arteries. And then we want to make sure that the blood is thin. And of course, if you gave a lot of IV fluids, that would help with ensuring that the blood is thin and moving quickly so that blood moves quickly through the arteries. So again, because treatment is prescribed by a physician, you're not going to be asked which drugs to prescribe or which drugs you would expect to prescribe. You're going to be asked about the concept, and the concept is subarachnoid hemorrhage with vasospasm. We're going to use Triple H therapy. Again, once this therapy is initiated, patient assistance assessments, including frequent neurological checks, will be performed. That's pretty much it for our intracranial problems, and that covered ischemic and thrombotic strokes as well as hemorrhagic strokes, including the subarachnoid hemorrhage. And then the last thing I want to just mention is I'm not going to go over this content because I have copied and pasted all the content in the neurologic Cues, Clues, Intracranial Problems worksheet, but I just want to remind you to make sure you look at it. There is always at least 2 questions on neurologic disorders, neurologic problems, and that includes the amyotrophic lateral sclerosis, ALS, otherwise known as Lou Gehrig's disease, Guillain-Barré, and myasthenia gravis. Make sure you look, just kind of briefly read this information, and then I have some of this information covered in the practice questions. Again, go through the intracranial practice questions and or email me if you have any questions about the content.